Autonomic dysreflexia. Please like and subscribe. Key points: it's a medical emergency. It occurs in patients with a spinal cord injury and leads to an abnormal autonomic response to a stimulus below the level of the lesion, leading to severe hypertension, and this is usually characterised as a blood pressure greater than 25 mm mercury above baseline. The clinical features are based on the degree of sympathetic response, the level of the lesion, and the location within the body. The cardiovascular features include sweating above the level of the lesion, pale, dry skin below the level of the lesion, and palpitations. Neurological symptoms include headache, nausea and vomiting, dizziness, anxiety, and visual changes can also occur. Autonomic dysreflexia occurs in at-risk patients with a spinal cord injury, usually from 1 month to 1 year after the injury, with a high injury usually above T6, but it can occur at low injuries above T10, and the lesion is usually complete. There's a trigger. Pain induced by bladder distension, constipation, or pressure damage are just a few examples. This will lead to an exaggerated sympathetic response below the level of the lesion. This effect may be enhanced if the lesion is above T6 due to vasoconstriction of the splanchnic circulation. This will lead to hypertension and possibly even reflex bradycardia. And this is due to the absence of descending inhibitory pathways below the level of the lesion. The management is based on the underlying etiology, so identify the cause, for example, manage constipation. If the blood pressure is persistently high, you could consider additional agents. Short-acting antihypertensive agents include GTN, nifedipine, hydralazine, or clonidine. If the patient is under anaesthesia, consider increasing the depth of the anaesthesia. The complications relate to end organ damage. These include MI, seizures, AKI, and retinal hemorrhage.